All right, let's jump straight into this high-yield meningitis study guide. We're taking some pretty dense clinical guidelines and turning them into a visual framework to help you absolutely crush your medical board exams. Welcome to this explainer. If you're prepping for boards right now, you already know meningitis is heavily tested. And let's be real, the question writers specifically designed these vignettes to trip you up on the tiny nuances of diagnostics and empirical treatment. So today, we're going to lock down those key criteria and treatment tables so you never miss these points again.
We'll be following a clinical reasoning funnel today. Section 1, pathogenesis and presentation. Section 2, diagnostics and CSF. Section 3, empirical treatment. Section 4, spotting viral meningitis. And finally, Section 5, chronic variations. We're going to move efficiently through these, mapping the exact flow of a board exam vignette right from the moment the patient walks in down to the targeted treatments.
Okay, Section 1, pathogenesis and presentation. Let's start with the foundational pathophysiology and exactly what clinical features your patients will have at the hospital doors.
So the crucial point to understand here is step 4. It all starts with nasopharyngeal colonization, right? That leads to a blood-brain barrier breach and rapid multiplication in the CSF, where, let's face it, the host has practically zero defenses. But here's the thing, it's that final step, the inflammatory reaction, that does the real damage. The lysis of the bacteria triggers this explosive release of inflammatory markers like TNF-alpha and IL-1 beta. This reaction causes the edema and the dangerous spike in intracranial pressure. And here is a massive board concept you need to remember. Neurologic injury can actually progress even after you've sterilized the CSF, purely because of this ongoing inflammatory cascade.
Now, how does all that inflammation actually present clinically? Well, while the classic triad of fever, headache, and nuchal-rigidity isn't always complete in every single patient, decreased consciousness is incredibly common. We're talking over 75% of cases. You've also got your classic physical exam findings, Kernig's sign, where extending the knee causes pain, and Brzezinski's sign, where flexing the neck makes the hips and knees spontaneously flex. But pay super close attention to the rash. Watch out for a petechial rash turning purpuric. That is a massive red flag from meningococcal meningitis. If a vignette mentions a rash starting maculopapular and rapidly becoming petechial on the trunk or extremities, and meningitis needs to be at the absolute top of your differential.
Board exams absolutely love testing demographics. You need to immediately link the patient's age to the most likely organism. Notice how S. pneumoniae and N. meningitis dominate those middle age brackets? But look at the top and bottom rows. You have to immediately link a neonate under 1 month, or a patient over 60 to Listeria monocytogenes in your mind. As we'll see in just a second, identifying that high risk for Listeria completely changes your empirical treatment plan.
Great, moving on to Section 2, diagnostics and CSF. What's really interesting here is how it highlights classic board traps regarding your order of operations.
The examiner is definitely going to test if you know when it's safe to perform a lumbar puncture immediately versus when you absolutely must send the patient for a CT scan first to rule out a mass lesion or severe swelling. On the left, we've got the absolute indications for a CT before an LP: papilledema, focal neurologic deficits, altered consciousness, a history of seizures, or an immunocompromised state. But if your patient matches the right side, meaning they're fully conscious, immunocompetent with no focal signs, you are cleared to do the LP right away. However, there is a golden rule here you cannot forget if they do need that CT.
Listen closely to this one. If a vignette says the patient requires a CT, draw your blood cultures and start antibiotics immediately. Do not wait for the scan. Never, ever delay life-saving antibiotics while a patient is rolling down to radiology. The board exams will throw answer choices at you suggesting you wait for the CT or the LP before giving meds. Those are trap answers. Blood cultures first, then antibiotics immediately, period.
Okay, you got to memorize this holy grail CSF table. Look at the stark differences here. Bacterial meningitis shows a massive white blood cell count with PMN pleocytosis, meaning mostly neutrophils, and a highly suggestive glucose ratio under 0.4. Basically, the bacteria are in there eating all the glucose. Viral cases, on the flip side, typically maintain normal glucose levels and show lymphocytic pleocytosis. And what if you see lymphocytes combined with shockingly low glucose and very high protein? Your brain should instantly jump to the TB or fungal column.
Section 3, empirical treatment. With the diagnostics sorted, let's look at exactly what empirical therapies you need to trigger based on the patient groups we were just talking about.
Here is your high-yield, if this, then that clinical trigger table.
For your standard community-acquired adult case, your go-to is ceftriaxone, vancomycin, dexamethasone, and acyclovir, just in case it's HSV encephalitis. But remember that demographics table? If the patient is over 55 or under 3 months old, you must add ampicillin to your standard regimen to cover listeria, because listeria is naturally resistant to cephalosporins. Also, keep an eye on that post-neurosurgery row. Ceftriaxone won't cut it there, because you need to cover Pseudomonas, which is exactly why we switch over to ceftazidime or meropenem. Let's talk about the dexamethasone component for a second, because the timing of it is a highly tested concept. You have to remember it must be given 20 minutes before your antibiotics, or at least concurrently. Why? Well, because you need to effectively inhibit that TNF-alpha production at the mRNA level before the antibiotics lyse the bacteria and trigger that massive inflammatory cascade we talked about earlier. If you start the dexamethasone more than 6 hours after the antibiotics, it's practically useless. Oh, and one critical side effect to note, it actually decreases vancomycin CSF penetration, so you often have to compensate with higher doses.
Moving right along to Section 4, Spotting Viral Meningitis. Let's see how viral meningitis, often called aseptic meningitis, builds a completely different clinical and diagnostic picture.
Aside from the CSF profile, which remember, features normal glucose and lymphocytes, the absolute easiest way to rule out viral meningitis on a board question is the clinical presentation. Specifically, pay attention to what's missing. The presence of stupor, coma, or focal neurologic signs points straight to a bacterial infection or encephalitis. Viral meningitis simply doesn't typically cause profound consciousness disturbances or seizures. Basically, if your vignette patient is in a coma, do not pick viral meningitis.
Now, if you do diagnose viral meningitis, you definitely need to know the most likely culprit. Over 85% of all identified viral meningitis cases are caused by enteroviruses, and these frequently present with a very distinct summer or fall peak. So picture this. You get a question about an otherwise healthy young adult with a severe headache, mild neck stiffness, normal CSF glucose, and it just happens to be August. Enterovirus is your prime suspect.
Section 5, Chronic Variations. Finally, let's contrast our acute cases with these heavily tested variations: TB, fungal, and syphilis. These tend to smolder over a longer period and have some really unique diagnostic hooks.
For tuberculous meningitis, the CSF is going to show high protein and deeply suppressed glucose with lymphocytes. But here is the major testing point. The acid-fast bacilli, or AFB smear sensitivity, is incredibly low. So to maximize your chances of actually finding the bacteria, always remember this exam pill. Test the pellicle, that cobweb clot, from the absolute last tube of CSF drawn. The treatment is a long haul of the classic IRPE regimen for 6 to 12 months, plus dexamethasone.
Next up, cryptococcal meningitis. You'll typically see this in immunocompromised patients who've been exposed to soil or bird excreta. You diagnose it using the highly sensitive cryptococcal antigen or an India ink smear. But here's the big board trap. How do you monitor treatment success? Do you just keep checking the antigen titer? No way. You must follow CSF yeast cultures for sterilization. The antigen titer can actually remain elevated way after the infection has cleared, so don't fall for that one.
And what about neurosyphilis? Examiners love testing the nuance between these two major CSF tests. A reactive VDRL test in the CSF is definitive. It confirms the diagnosis right then and there. However, a negative VDRL does not rule it out. For that, you absolutely need a negative FTA-ABS test to confidently say the patient does not have neurosyphilis. Conversely, a positive FTA-ABS isn't definitively diagnostic because it can be falsely positive from just a tiny bit of blood contamination during the lumbar puncture. It's a perfect puzzle for a multiple-choice question. As we wrap up this clinical reasoning funnel, I want to leave you with one final provocative board question to test your active recall on chronic meningitis complications. Think carefully about this one. What is the most common complication of fungal meningitis?
The answer is hydrocephalus. The thick, inflammatory exudate of a fungal infection literally blocks the normal reabsorption of CSF. When this happens, you'll need to manage it with a CSF diversion device, like a ventriculoperitoneal shunt. But remember, you can only do that after you've proven the cultures are sterile. Keep mastering these specific diagnostic triggers and clinical patterns, review the tables we covered in this explainer, and you are going to completely dominate your board exams. Thanks for learning with me today, and keep crushing it.